Hello, good afternoon to everybody, or good evening. First, I would like to welcome all to the first EPOS webinar on flexible nailing. Where are the limits? The pandemic COVID-19 had a tremendous impact on EPOS, educational activities, and this webinar is actually the reflex of the present time. But our president, Thomas Weir, will talk about this and the EPOS activities for the future. After his talk, we'll have Silvio Bellezini giving a word from Orthofix, the company that we are very thankful for, since without their support, it would have been impossible to organize this webinar. After, we'll move forward finally to our webinar. We are lucky to have with us two experts on the field, both coming from the Nancy School, the birthplace of the flexible nailing. Pierre and Damian. They will give their talks on their views and insights on the technique and what we can expect for the future in this area. Just a technical point for all of you to allow interaction. We want this webinar to become a live webinar. So on the right side of your screen, you have a question and answer box where you can write your questions. Please feel free to do so anytime during the webinar, and at the end, I'll be happy to pass them to the speakers for discussion. So, welcome on board, and I will pass now the word to our president, Professor Thomas Weir.
Dear colleagues, dear friends of EPOS, it's a great pleasure for me to welcome you to the first EPOS webinar ever. This is, as Manuel explained, the result of our COVID-19 pandemic and the reaction of EPOS to maintain educational activities throughout the community of pediatric orthopedic surgeons. This is the first time we meet like this, and the topic is very attractive, flexible nailing. Where are the limits? We will continue this by monthly webinars, but it will not only be webinars which EPOS wants to present to you virtually. We will develop further other possibilities of interactions through the net to extend our educational basis and to improve education, even if we cannot meet in person. But of course, we would like to meet in person as soon as possible again. And then we will build up a combined virtual and real education program, and that may actually be the future. Now I wish you a lively and very informative webinar, and I hand over to Silvio Bellezini from Orthofix, who I thank very much for his support, or the company's support, to make this webinar happen.
Thank you very much. I'm Silvio Bellezini, Global Marketing Manager, Pediatric and Limb Reconstruction for Orthofix. I'm honored we have been given the opportunity of being the sponsor of the first online symposium organized by the EPOS Society. One of the most famous quotes regarding training says that, give a man a fish and you feed him for a day. Teach a man to fish and you feed him for a lifetime. We believe that training and education can really make the difference and can help companies and surgeons to achieve the common goals, that is, helping the patient's lives. This is our goal in Orthofix, and specifically of our internal junior ortho line dedicated to pediatric patients. And that's why, as first topic for this webinar, we choose together with the panelists the elastic nail. In fact, the product can make the difference, as you will see, but it's the surgical technique that plays the most important role to get the best outcomes. So I am quite confident you will enjoy the session. And with that, I leave the stage to the panelists and to Dr. Cassiano.
Thank you, Thomas, and thank you, Silvio, for your introduction. And I think it's time for us now to start with the webinar. And first, we're going to start with Pierre. You know, we all know Pierre. I don't think he needs introduction. He was one of our past presidents of our society. And of course, he spent a lot of time in Annecy, as I mentioned, the birth of the elastic nailing. And then he moved on to Geneva, Switzerland, where unfortunately he decided to retire. But he's also a bright mind, and he's going to give you insights on the limits of the axing. So Pierre, come along.
Thank you very much, Manuel, and thank you to all of you to be with us tonight. I think it's a great time, and you are all familiar with flexible nailing, and you know that in some situation people say that we can do use this method is in many different aspects, and others complains of many difficulties. So what we are going tonight is to talk about the limits of the method. The first limit is, of course, your knowledge of the technique. You see Jean-Paul Mettezo on the right, and in the book we've written on this technique, he wrote at the beginning of the book that it's apparently simple to do it, of course. And the problem is that many surgeons thinks that it's easy to do it. And when they have some complication, they criticize the method, and they don't realize that sometimes it's just a lack of experience. But you are familiar with all these things. Of course, the keystones here is the principle of the stability. This was really described by Fiorica, a Romanian guy in the 80s. It is totally different that to introduce one nail, one straight nail into a bone, you know. And these two nails facing together lead to a stability. And of course, you are familiar with the rules of crossing above and below the fractures, maximum bend at the fracture site. But in some situation, like in the tibia on the right, you decide yourself to induce or to go against a deformity, for instance, in the valgus in this situation. So you are the surgeon, and you know that you decide of what you have to do. The second point is unstable fractures. There are different classifications in the literature, and you may have some unstable fracture with a third fragment, and you see here the classification described by Winquist with a type 1, 25% or less of the whites of the bone with a third fragment, 50% type 2, more than 50% type 3, and type 4 communitive fracture. Another way is to measure the length of the fracture compared to the diameter of the cortex, and if the ratio length divided by the canal diameter is above 2, this is a really unstable fracture. But you have many examples with, you see, this ratio wide above 2, it's 5.5. This one with the femur on the right is 4.3, means that it's possible to use this method even in this considered unstable fracture. What you can find in the literature. A recent paper in the GBGS compared flexible nails with plates, and you will see that the operative time is quicker with flexible nails, significant, blood loss significant, less with flexible nails. Hospitalization day, a big tendency, better. The cost, less than plates, and no difference, which is the most important, between shortening and angulation. I will say results. Of course, this group of age is very young, 6 years of age. But anyway, this has been published in the GBGS. The third point, which could be considered as a limit, is the body weight and or the age of the child. All of you know that this paper published in 2006, again in the GBGS, defined a kind of cut around 50 kilograms, saying that below 50 kilograms, you had more satisfactory outcomes compared with above 50 kilograms. And in the US today, the limit of 50 kilograms represent something above you should avoid to use flexible nails. And this is why the recommendation, the current recommendation of the American Academy says that in this group of age between 5 and 11 years, the use of the flexible nails is probably the best solution for the fracture of the femur, of course. And if you go back to the literature again, you see this recent paper in the Journal of Children Orthopedics, comparing about body weights. You see 54 fracture of the femur, underweight patients 14, normal weight 20, and 20 obese patient. And the result regarding shortening, AP angulation, varus and valgus angulation showed that there were no significant difference between all of these, which means that the stability was obtained with all these patients. But again, in this group, the mean age was for me very low. But anyway, that means that obese patient could be easily treated with this method. Again, this paper in the Journal of Pediatric Orthopedics 2 years ago compared patient above and below 100 pounds kilogram, almost 50 kilograms. That was in a single institution made by 17 surgeons. And you see in this paper that the age is different, okay, but there is again no difference of shortening angulation compared with patient below 50 kilograms and patient above 50 kilograms. And in addition, they had a subgroup above 120 pounds, and you see no differences. So the fourth point to discuss about the limits is, for me, the size of the bone. And you remember that every lecture I give, I explain that when you decide to do a flexible nailing, first you have to measure the diameter of the canal, and 40% would be the minimum of the diameter of the nail, which means that with nails you should find in the industry, usually they are 4 millimeters, the bigger size. The limit is 10 millimeter for the canal, medullary canal. This was demonstrated by this paper published 7 years ago. And in this rock curve, you realize that when you have a ratio above 35%, I will say 40%, we will find neither angulation nor shortening, nor malunion, nor non-union, and so on. So this limit of the ratio 40% is for me very important. So if I conclude the limits of ASIN today with most of the nails available on the market, I would say for the femur of the tibia, first, the knowledge of the technique, that's the problem of the surgeon. Second, the stability of the fractures, and you have seen that in some circumstances you can use this method. Third, the age or the body weight, but I will say that the most important for me is the size of the bone and the famous 10-11 millimeters. Now for forearm and humerus, of course, the knowledge of the surgeons, but behind this, there is no limit in children and adolescents, as it will be always possible to use this method in flexible nail technique. Now the question, and this is the topic of this webinar tonight, Jean-Damian Mettezo has described new nails. He will explain to you, and you see that this is the classical nail, circular like this, and here you have a bigger nail with this flat part. And the question tonight to solve is, Jean-Damian Mettezo able to go over my limits, I will say. He will speak about these cases. For instance, a boy 16 years old, 62 kilograms, almost an adult. Of course, I would suggest a nail, but perhaps there is still a solution with this MGflex nails. A second example, 14 years old boy, 70 kilograms, diameter 12 millimeters, quite difficult for a classical flexible nails. A good solution would be a lateral trochanteric entry nail, but again, perhaps with this new nail, you may solve the problem. Distal fracture of the femur, which is the most difficult to treat with a flexible nail. Many surgeons will prefer to have plating with some submuscular plates or locking nails anyway, but perhaps again, we will see that the solution is with this MGflex. And in this unstable humerus, what kind of treatment you will decide? Perhaps a Sarmiento or a cast or whatever, but perhaps also the solution is with this MGflex nail. So I will introduce Jean-Damian Métézeau. First, Jean-Damian is Jean-Paul's son. This is of course important, but it's not enough. Jean-Damian is very brilliant, clever, and skillful surgeon. I know him very well because he spent many years in my department in Nancy. He was resident and then chef de clinique. And then he moved to Dijon in France, where he is doing exclusively pediatric orthopedics. And recently he published this paper, and I suggest you to go to this very good paper, which demonstrates clearly biomechanics of this new shape of nails. So Jean-Damian, I will give you the microphone now to explain how are your nails.
Thank you very much, Pierre. It's a very huge honor for me to be part of this first webinar. We don't have that much time, so I will go straight to the topic. We have much to discuss, so let's begin. So, as Pierre said, ESIN goes from very easy to very difficult. And he said also, and that's right, a lot of surgeons, they probably don't really understand what is the technique. The aim here is to show what can be done. I want to show you where you can push the nail. I don't want to show you what you should do. It's up to you. But maybe with this, after you will think, oh, maybe I can do elastic nailing in much more cases than I think. Of course, there are many key points in the technique, but we'll focus on the 5 most important. The first one is the difficulty. This is not an official classification, but it will give you an idea of how probably difficult or not will be an elastic nailing. And as Pierre said, there is 3 factors. The first one is the weight. So let's put the limit to 50 kilo. The second one is the fracture, if it's unstable. And the third one is the fact that the fracture is proximal or distal. So if you have none of this, it should be easy. If you have 1, it should be moderate. If you have 2 and 3, it should be hard. And if you have all these factors, it's probably very hard. Unless you are very skilled in the technique, probably you should look for another option. Now, the key point number 2, the nail. You go, you are going for elastic nailing, and of course, you will have to choose which nail you will use. First one, will I go for stainless steel or will I go for titanium? In my opinion, in most of the cases, it doesn't matter much. You can do both as you want. But just keep in mind that titanium is really easier to manipulate. So if I can, it's always my first choice. But stainless steel is 2 times stronger than titanium at the same diameter. So if you really need some strength, I suggest you go from stainless steel. The bending, about 30 degrees at the tip of the nail, on about 1 centimeter. Of course, it depends on the size of the nail. And we could speak about a lot of that, but generally speaking, and you want a regular bending in one plane, like in this case. You don't need to bend your nail too much. That's not necessary. If you have the good size, it will empty it will fill the canal, and you don't need to bend them too much. And then the diameter, as Pierre said, is very important to use the biggest nail possible, at least 50% of the medullary canal. And this is so important. It's why we choose to make a new nail with Orthofix we call the MGflex. And the idea was to increase the filling of the medullary canal. And if you look at a standard nail, even if you have a big size, if you make some calculation, you will see that you cannot fill more than 1/3 of the canal. So the idea was to increase this filling. And if you use, for example, a standard nail of 4 mm, in the MGflex, it will be 4/5. It's made for a manual 5, and one side is flattened. So what are the advantages? As Pierre said, we published a clinical and biochemical study. It was more than, we have more than 140 patients, something like that. So first, it will increase the stability in all the plane from almost 2 to 3 times. You will have a better lock on the T-chuck handle, so it won't slide when you turn. The flat size allows you to know the position of your nail at all the time. This will decrease the amount of X-ray and the operative time. There is no change in the surgeon habit, and it decreases also post-operative pain as you have better stability. So just try them and give us your feedback. The surgeons seem happy with them right now. So an example, it was one of the cases that Pierre showed you, say 16 years old, more than 60 kilos, and it was a floating knee because it's the same leg on the same patient. And you see you have on each 2 on 3 criteria, you have unstable fracture and heavy weight. And as Pierre suggests, you could have done rigid nail, of course, that's right, but you could also use elastic nailing. It was titanium 5, and you can see that the reduction is almost. Now we have the good size of the nail, and what is the key point number 3? It's the nail balance, and this is, I think, the point that most surgeons they don't understand. So we'll spend a little more time here. So look at this case. It seems not difficult. It's not so heavy. We have maybe an unstable fracture, and still we don't have a good result. And the surgeon even tried to add a cast. It's not a good cast. But when you look at the nailing, you see that the nails are almost, coiling. They are facing each other. They are too thin. So what we did, we changed the nail. We make for a bigger size and with a new orientation. And this is really important because, as you can see, they face laterally. Probably a little too much in this case. And here is the reflection I want you to have. When we teach elastic nailing, most of surgeons teach elastic nailing as a bipolar device. And you see this perfect picture with 2 nails facing each other in a frontal plane. But this is true only in theory when you go on a sawbone on an undisplaced fracture. But in reality, you have damages to the soft tissues. And these damages, they will create a main deforming force. And this main deforming force, we will have several components. So what are they? First one, you have the shortening and how you will deal with traction. You can go through the fracture life with another lap. So you need traction to take this problem. Second one, you will have rotation. You will deal with external derotation. Third one, you will have translation. You will deal with your nail. If you have the good size, they will almost fill the medullary canal and you will have no translation. It's not totally true if you have proximal or distal fracture. It's why they are a little more difficult. And then it will let you the valgus or varus and a recurvatum or the flexum. And how will you deal with this? with the balance of the nail. Look at this picture. Imagine, look at this fracture. It was kind of the same that Pierre showed. Fracture tibia, there is a deformation also of the fibula here, but here you can see that there is a varus, a main deforming form in varus. And what did the surgeon? He put these two nails facing each other. And if you look at the forces, you have the deformation in red, and you have one nail with opposite to the nail, and one nail within the same direction. It's not good. So this is wrong. Now imagine you have a vector in 90 degrees for example, in this recurvatum. Here, the two nails are perpendicular to the deformation. It's better, but it's not perfect. If you want to pull, you go the other way. So you should have the deforming forms here, not perpendicularly to the deformation. So it's also wrong. So what should be the correct orientation of your nail? Probably something like that. You have the deforming force, and you have two nails at 120 degrees to have here a perfect balance, right? You need that the vector of the force created by your two nails is the same as the deforming force. And you can see here in this example, there is two fracture here. The nails are laterally and anteriorly, and you have a perfect reduction. So here is the main point I want you to understand. Elastic nailing is not a bipolar device, it's a tripolar device. And the aim of the nail is not to create a balance between each other, but it's to create a balance with the deforming force. You don't want them to just oppose each other. Of course, if you have an unstable, a very stable fracture, it will work. But if you have unstable fracture or heavy patient, it won't work. But is this really correct? In fact, it depends. Because if your deforming force is really strong, your nails are not strong enough. So you need to increase their power by put them in opposition to the deforming force. If the deforming force is not so strong, your nail is too powerful, you need to release their power. So you have to adjust the balance of your nail. So how would you do that? It depends. If you have, for example, a valgus, you will turn the lateral nail so it looks medially, internally, to correct. If it's a varus, of course, you turn the opposite nail. If you have, for example, here a recurvatum, you will push your two nails so they look posteriorly a little, so you can change, you control the force and achieve a good balance. So you have to follow, when you go for elastic nailing, you have to follow the steps. First one, you will, of course, you will reduce your fracture. Then you will go through the fracture side with your nail. You must stop before you enter the metaphysis. And now you can set up the rotation. When you enter the metaphysis, the nail will go in the metaphysis. It's too late to set up the rotation. So just before you enter, you verify that your rotation is good. If you have a traction, you must release your traction because you will add another forces and you won't have good results. So you must release your traction. Then you will use external maneuver to reduce as best as you can your fracture and enter your nail in the metaphysis, about halfway. Then you balance your nail to achieve a perfect reduction. And when you're happy, you lock the device by pushing the nail into the metaphysis. And this will allow you to have a perfect reduction. So let's see this about another example. 14 years old, 70 kilo, unstable fracture, 2 criteria on 3. What was done is this. And as you can see, it's titanium 4, it's not strong enough. But the surgeon, he understands the concept. So he tried to turn his nail laterally to correct the deformity, but the nail was not strong enough. So what he did, he changed. He changed for stainless steel 5. It's better, but this time, strangely, he didn't turn this nail. This nail should look laterally. So it's not perfect. There is still a slight varus, but what he should have done is like this one. And it was a very heavy patient. This one was more than 100 kilo. And you can see the nail are really facing laterally and anteriorly. And there was a third fragment. You have a perfect reduction. Another example here, another heavy patient, unstable fracture. The nails are facing each other, but it's wrong. There was a third fragment. So we change the nail. So they look internally and you have almost a perfect reduction. Maybe in this case, it could have been a good idea to add a nail in the fibula. Sometimes it's very useful in heavy patient for unstable fracture. Let's speak now about the key point number 4, the type of ESIN. Look at this fracture Pierre showed you. It was distal fracture, heavy patient, and we have almost 2 and 3 on the criteria. And what was done is this: try to go on elastic nailing. There is a poor result. And why? First, the nails they don't go deep enough, and there is a cortex perforation here. So, of course, what could have been done, as Pierre showed, you could have used a plate, but we prefer to go for another elastic nailing. And you can see here there is a perfect result. This one is not perfect because the nail are maybe 2 in the center, and it should have been probably more like in this case. And because you want to have 1 nail in each column to have really a good, strong device. And you can go through the fracture, the growth plates, as long as you don't go many times. But if you just push your nail just above and just push them 1 time, it's okay. You won't have any trouble. And another example here of the same kind of elastic nailing. Again, more than 50 kilo, unstable fracture distal. So here you have 3 on 3. And again, with an elastic nailing, it's possible. With only, it's only titanium 4.5, so we could have used much more stronger. And here you can see there is a perfect result. So this to show you what we call elastic pinning. There is in fact 2 kinds of elastic. You have the classical one, elastic nailing, and you have elastic pinning. And elastic pinning is the same when you use for example, supracondylar fracture, for distal tibia fracture, radial neck fracture, proximal humerus fracture. And the idea is you won't use much the elasticity of the nail, but the idea is just to pick the nail, to pick the bone, excuse me, with your nail. And for this, you need to have sharp tips. And I know a lot of surgeons, they complain about our nail to be a little too sharp, but they are sharp for this reason. Because in my experience, this elastic pinning is almost 1/3 of the case. And if you don't have the sharp tip, you will just push the bone and you will not be able to enter deep inside it. But if you don't need the sharp tip, you just can cut a few millimeters if you want to make the nail a little more blunt. So 2 kinds of elastic nail. For the balance, it's the same rules. You can change the orientation of the nail, and you will manipulate the distal of the proximal fragment with your nail. Last point, for this presentation is the tip and tricks. You don't want to struggle with basics in every indication. So I will give you a few tricks for each localization. For the clavicle, just be careful with the entry point. You don't want to slide because there is big vessels behind. Don't try to push the nail too far because it's quite difficult to go very long way here. So when you just have crossed the fracture site, it's okay, it's stable enough. And it's better for mid-shaft fracture. It's very difficult when you have very lateral fracture. For the humerus are not so easy. Sometimes it's very difficult to push the nail. On the installation, be careful with the metal of the operative table. You don't want to have the metal in your X-ray. So just check if you have to push the patient or pull it against you. The entry point, usually it's laterally with 2 holes, but sometimes you cannot do that. For example, for this example that Pierre showed you, if you put 2 holes laterally here, you see the 2 nails, they won't have much time to change the direction. So it's why in this case, sometimes you can go one externally, one internally, like you would do for any other bone, and you have a very good result. And use a sharp hole or a drill because it's hard bone and it's really, really easy to slide. For the forearm, here the balance is really easy. As you have one lane, you just want that the nail face each other. So you want to put some tension in the membrane here. The size, you will increase a little as you only have one nail, so you can go for 60% of the medullary canal. The entry point on the radius, be careful, there is a nerve and the extensor, the growth plate also. On the ulna, not too internally, or the patient will complain when they push on the table, for example, so a little more externally. And sometimes it's quite difficult, so don't hesitate to open the fracture site. I think don't struggle hour. Personally, I try 2-3 times. If it's possible, I just make a small incision and I open. It's better. And here, just this case to show you, because some surgeons often ask me what you do when you have this kind of fracture, right? Not really distally, but not really diaphyseal. So you can make a small elastic nailing. You just want to stop your nail here. Don't push them too far. And you have a kind of small elastic nailing. It works quite well. For the femur, of course, it's the indication of the elastic nailing. There is not much to say. The installation, you can use a traction table, or if you don't, personally, I put a sheet between the leg. So if I need to pull, the anesthesiologist can pull against me, so I won't take the patient with me. And it could be very simple to very difficult. The tibia fracture, for me, it's probably the easiest because you have a very big diameter, even if in small children. And this is important. There is no differences. I often heard surgeons say, oh, tibia is a triangular shape. Yes, there is triangular shape outside the bone, but inside the medullary canal is circular. So there is no difference. You do it like you do for any other bone. Proximal entry point, be careful with the anterior tuberosity. And if the fibula is not broken, consider it the first nail. We saw on some example. And sometimes it's you have, like I show you, you can put a nail in the fibula. It could be quite useful. So if we take all these key points, first one, know the limits, who are probably more, as Pierre said, your limits. Choose your nails, a good nail, titanium, stainless steel. If I need strength, I will go for stainless steel. Always a bigger diameter. It's better to put maybe a bigger nail and say, oh, it's too big, I take it off and put a smaller size, than to be happy with a small size and then you will have a bad result. Don't go with every step and balance your nail. Enter the fracture, go through the fracture site, check the rotation, release the traction, reduce your fracture, push your nail, balance them. Just keep every step. Don't go too quick. Remember, there is 2 kinds of elastic nailing: the elastic pinning and the classical one, elastic nailing. And know the tricks for relocalization. You don't want to struggle because you have a bad X-ray, a bad installation, something like that, whatever, I don't know. So in conclusion, I think that elastic nailing can be used in a lot of cases if done properly, and probably more than 95% of the fracture. The limits really depend on the skill of the surgeon in the technique. So the indication will probably change for a surgeon to another and probably change with the experience. As we grow better and better in elastic nailing, maybe we'll put more and more. Of course, they are not always the solution. but studies demonstrate they have the best ratio benefit risk against a plate, an external fixator, for example. So for me, it's always my first option. If I have a patient and I need an osteocentesis, I will think, can I use an elastic nailing? If I can, I go. If I cannot, for whatever reason, I change. Thank you very much. So I think we have some time for a question. Manuel,
yes,
if you have some questions.
Thank you very much for both of you for those two interesting talks. I just, for our participants, I just want to remind you that on your right side of your screen, you have a question and answer box. So you can send me your questions and I'll be very happy to pass them on to Pierre Lascombe and Jean-Damian Mettezo. So probably what we're going to do now is starting a little bit with some of the questions here. And first of all, I think I would like to know, because you talk about the upper limits in terms of the age. Do you have any lower limits? Because we have seen now that with these new techniques, we have seen a change in terms of the people approach the fractures and try to be a little bit more aggressive. We know all the social impact that we want the children to be back to school, to their own activities. But still, you think there is a role for the non-operative treatment in a young child? What will be your under limit age for operating a child?
I think Jean-Damian starts.
I think it's really depend of the, in fact, there is no lower limit. You can do an elastic nailing whenever you want. But I think it depends really on the patient. For example, if I have a fracture, my first idea would be, do I need a cast or an elastic nailing? If I can go for a cast, I go. If I need to have a reduction on the operative feet. And this time I will ask to the patient and the family. I say, okay, I can go, maybe I will be able to reduce the fracture and you will have a cast for this time. Or if you don't want a cast, I can use an elastic nailing. So I explain both and I let them choose. What do you think, Pierre?
I think that we can differentiate bones. For instance, if you take the femur, we started with the lower limit at age 5, 6, school age. But today, you have two options, a kind of spica cast in a boy 3 years old. If you compare with an elastic nails, probably you have more difficulties with the cast. And if the surgeon is really familiar with this technique, as Jean-Damian says, we propose to the parents both, but we realize that very often they prefer the surgical way. And it's really strange because in the papers I've presented to you, you see that the age group in femur for me is really, really low. It's perhaps because of the recommendation of American Academy, which start 5 years old, but probably it's nice as soon as they are 3 of age, which is quite not so frequent. Now, if you move to forearm fracture, the problem with conservative treatment is to be sure that you will not have any secondary displacement. Because the worst thing for a family today who has a job and so is to go back to the hospital a second time 1 week later for a new surgery, new reduction or something like that. So I will say that I would propose conservative treatment one shot if I'm sure that it will not displace under the cast. And if I have a doubt, I really suggest the family to go to surgery. In addition, when it's summertime and children have to appreciate to go to swimming, it's very bad after 1 month to I will say it's good to allow this patient after 1 month after the fracture to be able to have some activities with an elastic nails compared with a cast, which is totally different.
Thank you. I think we have a lot of questions here, and most of them regarding the unstable fractures. We have some questions when to prefer to use a solid nail with a lateral entry, or if you use some other device in terms of helping you to give more stability, like having a circle, adding a cerclage or an external fixator. Any hints for our participants how to manage these unstable fractures, in particular in the femur, that sometimes can be a challenge? We start with
it's
Pierre,
hard to say. Yes,
or
Pierre,
with Jean-Damian. Okay, go ahead, Jean-Damian.
Okay. So it's hard to say as each case will be different. It's hard to say to give something which works everywhere. But it goes with what we said. If you are very used with the nail and you use the big size, the good shape, probably you will be able to treat a lot of unstable fracture. But sometimes, as I said, it's not a good solution. If you have a really big unstable fracture on an heavy patient, you will need a rigid nail or maybe a plate, whatever you want. It's possible. I did it sometimes. You can put a nail and sometimes a cerclage around if you want. It's also possible to put elastic nailing with an external fixator. I did this on sort 2 times, but for me it's a failure. If you need to use elastic nailing with another and add a cerclage or add an external fixator, for me it's a failure for the elastic nailing. So, or what do you think, Pierre?
Sorry, sometimes there are interruption of your voice, but anyway. Again, with, I would say, classical flexible nails, diameter maximum 4 millimeters, my limit concerns the diameter of the canal, even if it's unstable. So now I look at the age of the patient regarding the growth. For the femur, it's easy. As soon as the patient is 10, 11, 12 years old, you can go through the greater trochanter with a lateral entry locking nails. But the problem is for the tibia. You know that it's forbidden to go through the tibial tuberosity below age 12.5 in girls and 14.5 in boys, because you risk a knee recurvatum. And in this situation, if you cannot add a third nail, for instance, personally, I will suggest to add an external fixator for 1 month and then you remove it. I would say, okay, I don't like external fixator, but it's better than a fixator alone. Now, with the new nails, MGflex, I would consider to try with these, of course, in this group of patients. But I have a question to you, Jean-Damian. How do you select the diameter of your nails? Is it by your knowledge, your skillness? Is it a rule you can explain to everyone here?
Oh, okay. So for the nail, it's easy. I go for the same rule that everybody, of the 40%, but with the MGflex, there is 2 options. If you look for the small or the big diameter of the nail. If you go for the big diameter, you will just take half of the medullary canal. So if you have a medullary canal of 10, you will use a nail of 5 on 4. And if you reverse and you use the same 40% that you would use for the classical nail, you have 10 millimeter of the medullary canal and 40% is 4, and the nail is 4 on 5. So you can whatever you want with the nail. But I use the same rules of everybody because you need a little some place around so you can move your nail, because if you have two big nails, the first one will go and the second you won't be able to push the nail, of course. And it's why the difference between the 2 diameter on the MGflex is 25%. So you can push your nail side by side or this way, not just facing each other. And if the ratio was a little higher, you wouldn't be able to put your 2 nails side by side.
I think we've answered to a question of our president, Thomas Wirth, who wanted to know how we decide in a patient 15 years old, but below 50 kilograms, just 49 kilograms. I think that all of us, we will say it's not really the age or the body weight, but the diameter of the bone. So you should look at the X-rays and measure. Manuel?
Yeah, we have so many questions that I'm overwhelmed with it. So I'm trying to select a little bit. And I have a lot of questions here. I think it's important to answer about this because people feel afraid about the unstable fractures. I have several questions where people were asking, when do you consider to use 3 or 4 nails? I think it's something that you should make a point out of this. Because in your technique,
Yes.
I think you
So,
should never, you go with 2 nails. Is
Yes.
it correct?
No. Oh, yes, because if you are yes. So the idea is that if you are able to use 3 nails, it means that your 2 nails, they are not big enough. Because if you have 2 nails the right size, you will almost fill all the medullary canal. So there is not much place for another nail. So if you can put 3 nails, they are too thin. You made a mistake. So you don't need, it's the same as, you know, the wire, electricity wire. The more you have, the more flexible it is. It's the same for the nail. If you have 1 rigid nail, it's 1 nail, a big nail. It's more strong than 2 nails, and 2 big nails are more strong than 3 nails. So 3 nails is never a good option.
Now we can help those who are asking for this question, because in the true life, you have, for instance, the tibia, and definitively the tibia is the most important. Instable, you put your 2 nails and you are not happy. You can try to put a 3rd nail, but it's not so easy and probably you will not be happy. Because you cannot change your mind. You are not going to put a submuscular plate or a locking nails for a reason of growth. At the end, just add a X-Fix for 1 month. This is the solution. But I don't like to have too many nails. It's complex.
The other thing that I realized from Jean-Damien's presentation is that maybe we have to rethink about a little bit how we handle this elastic nailing, because changing the concept from bipolar to tripolar, I think it's a big advantage in terms of really playing with the muscles around and not just with the bone. And I think that most of the problems that we have sometimes that we feel that we are unstable, it's because we are not correcting the deformity forces of the muscles around the fracture. What do you think, Jean-Damian?
Yes. Yes, yes. As I said, it's the main topic that most surgeons they don't understand. And also, don't hesitate if you have community fracture or unstable fracture to go from stainless steel. Huh? Stainless steel, as I said, is 2 times stronger than titanium at the same diameter. So you will have much more power with your nail. It's a little more difficult to push them, but really keep in mind the steps I show you to really achieve this balance. Because sometimes I saw surgeons, they come and say, oh, I don't understand. I have my really 2 nails facing each other, but I didn't have a good reduction. Yes, I said it was a femur. Did you release the traction? No. Oh, and did you balance your nail? No. So of course you don't have a good result. So you must follow your step. It's not when you are used to it, it takes no time because you just do it like that. But just at the beginning, think maybe like a pilot, you know, check each step to have a good reduction.
We have also several questions. Yes, Pierre, go ahead.
Yes, I think we can congratulate Jean-Damian because he's pushing us going back to trigonometry. And we know the forces developed by both nails, but the force developed by the muscles, we don't know. The key is definitively at the end of our fixation to move the femur of the leg and to see if there is any tendency for various deformity of the valgus or so what. And then try to add some opposition to this, which is very important. Thank you.
I have also here one question. Yes.
Just something is really important. When you balance your nail, always keep in mind which way you turn, because you don't want to make a kind of spaghetti. like you can have when you push your nail to the bone, you have only the one nail, you put the second nail, you can catch the nail, but even when you are making this balance, you can. So don't turn your nail like everywhere, just go one way. If it didn't work, go the other. Just be sure you don't do, because you will have a kind of entanglement with your nail and you won't have any more stability.
Yeah, that's was one of the questions here. I also have a lot of questions regarding the post-op period. How to avoid skin irritation, if you have any tips and tricks. Do you use plaster on the post-op? And do you change the rehabilitation if you have a heavy patient? Because exactly when you have a heavy patient, people feel afraid if you're going to put weight too soon, you can end up with a malunion or breakage or of the nails. So tips and tricks to avoid irritation in the skin.
Oh, I can show because I knew this question would come, so I just prepared the slide. So for the cutting the nail, my father, he described this like that, to really bend the nail and push them in the bone. The idea was that they can assure a kind of stability here. The problem is it doesn't work because it always goes out and you end up like that and you have trouble with the skin. So if you want to avoid, you must have your nail like this. Alors first, you be careful with your entry point. For example, the femur, it's wider here than there. So if you are too close to the growth plate, you won't have much place here and you are just under the skin. So just put the entry hole a little above here. And then when you cut your nail, I have a nail here, you just want to bend, someone is bending the nail like this, and stick, it will go and be flat along the bone. So you won't have trouble with the skin like that.
And what about the plaster? Do you ever use plaster? Because you know that some of the kids complain a little bit of pain in the post-op period. Do you find it's useful, or you never use a plaster on the post-op?
Me personally, I never use a plaster unless sometimes it could be, for example, even why not a fracture tibia, you don't have a good reduction, you want to add a plaster for 1 month, why not? But for me, if you need a plaster, it means it's a failure of the elastic nailing. So personally, I never use a plaster. Most of the time you don't need. And the pain is due to the instability. Sorry, Pierre.
No, I agree. Jean-Damian has been well educated, of course. So the end of the nails, he described, just lift up a little bit, but never like this first. Say never, but no cast. No need for a cast. We cannot imagine how a cast can help. Just in some forearm, a splint for pain for 1 week at least. But I would say you just treat more the parents than the child himself. And regarding rehabilitation, post-operative rehabilitation, I think that for the femur, which is the most important, start immediately by quadriceps muscle contraction, help the child to be able to raise up the limb about the bed. And when he's familiar with the control of his knee, he is able to walk with crutches. Now, regarding waist bearing, usually we wait for 3 weeks before allowed waist bearing. And I would say that obese patient or not, for me, is the same, and for the literature also.
Okay, I think that unfortunately, we have a lot of questions here still to answer, but unfortunately, we are coming to the end. I don't know if you have any if you want to ask a last question, Jean-Damian, Pierre, to yourselves. That is something that is important that you wanted to highlight.
I would just show, because I would just show to remove the nail, because a lot of surgeons complain. When you want to remove the nail, use a good tool. And me, I use a cutting tool like this. So I can bite in the nail, and with this, it's really easy to remove the nail, because when you want to catch the nail, it slide, but if here you can bite in the nail and you just hammer on it, and it's really easy to remove the nail. Because I said it because a lot of surgeons ask me the question how I remove the nail.
Mm-hmm. Yeah, sometimes it can be tricky. I think we need to find the right tool in some occasions to remove the nail. Pierre?
I would like to thank everyone, and I will say to the participant that if we have collected more questions, Manuel, we will answer to the question and find a way to send you some feedback.
Yeah, that was going to be my last remark. First of all, thank you for both of you for your tremendous presentations that were really helpful in your comments. I would like to thank EPOS and Orthofix to provide us this opportunity to be here with all of you. And as Pierre was saying, we'll try to answer all the questions that were unanswered. And if you have any doubts, you can also write to epos@epos.org, and we'll try to give individual answers to each of you. But last but not least, I would like to thank Sunny Hiltonen from our office. She is the EPOS Education Coordinator, and she did a really outstanding job in terms of preparing these webinars and the other ones that will come in the future. So thank you all, and have a good evening. Ciao, see you soon.